Professor Hammer's Neurological Assessment Masterclass. We're going to focus on the practical application of these assessments, aiming for accuracy and understanding that goes beyond simple memorization. The Glasgow Coma Scale, GCS. The GCS is a standardized, objective tool used to assess a patient's level of consciousness. It evaluates 3 areas: eye-opening, verbal response, and motor response. It's crucial to remember that the GCS is a snapshot of a patient's neurological status at a given moment and must be interpreted in the context of the patient's history and other clinical findings. Components and scoring. Eye-opening, E4 spontaneous, opens eyes spontaneously. 3 to speech, opens eyes in response to a spoken request. 2 to pain, opens eyes in response to a painful stimulus, e.g., trapezius squeeze. 1 no opening, no eye opening, even to painful stimuli. Verbal response, V5 oriented, converses and is oriented, knows who they are, where they are, and what time per day it is. 4 confused, converses, but is confused and disoriented. 3 inappropriate words, uses inappropriate or random words. 2 incomprehensible sounds, makes incomprehensible sounds, e.g., moaning, groaning. 1 no response, no verbal response. Motor response, M6 obeys commands, follows simple commands, e.g., show me 2 fingers, or wiggle your toes. 5 localizes pain, purposeful movement toward a pain stimulus, e.g., reaching for the source of the pain. 4 withdraws from pain, withdrawal from a painful stimulus, flexion at the elbow when pressing on the nail bed. 3 abnormal flexion, decorticate, flexion of the elbow, wrist, and fingers, adduction of the upper arms, and extension of the legs, sign of cortical damage, often above the midbrain. 2 abnormal extension, decerebrate, extension, abduction, and internal rotation of the upper limbs, and extension of the legs, sign of damage at or below the midbrain, potentially more severe injury. 1 no response, no motor response to pain. Total score. The GCS score ranges from 3, deep coma, to 15, fully alert and oriented. Clinical interpretation. Mild brain injury, 13-15, moderate brain injury, 9-12, severe brain injury. 3-8 important considerations. Always document the individual component scores, e.g., E3V4M5, in addition to the total score. The GCS can be affected by factors such as alcohol, medications, and intubation. Consider these in your interpretation. Observe trends in the GCS. Serial assessments are essential for tracking a patient's neurological status. A decrease in GCS score is always a concerning sign and warrants immediate investigation. 2. Reflexes. Reflexes are involuntary, rapid, and predictable responses to stimuli. Assessing them provides information about the integrity of the nervous system, particularly the spinal cord and peripheral nerves. Deep tendon reflexes, DTRs, these are stretch reflexes. You'll assess them by striking a tendon with a reflex hammer. Grading system. 0 no response, 1 plus hypoactive, diminished response, 2 plus normal response, 3 plus hyperactive, brisk response, 4 plus hyperactive with clonus, rhythmic involuntary muscle contractions. Key DTRs to know. Biceps reflex, C5-C6, strike the biceps tendon in the antecubital fossa. Expect elbow flexion. Triceps reflex, C6-C7, strike the triceps tendon above the elbow. Expect elbow extension. Brachioradialis reflex, C5-C6, strike the radius near the wrist. Expect forearm flexion and supination. Patellar reflex, L2-L4, strike the patellar tendon below the kneecap. Expect leg extension. Achilles reflex, S1-S2, strike the Achilles tendon at the ankle. Expect plantar flexion of the foot. Clinical significance. Hyporeflexia may indicate a lower motor neuron lesion, e.g., peripheral nerve damage. Hyperreflexia may indicate an upper motor neuron lesion, e.g., stroke, spinal cord injury. Asymmetrical reflexes are always clinically significant and should be investigated. Superficial reflexes. These are cutaneous reflexes elicited by stroking the skin. Abdominal reflex, T8-T12, Stroke the skin of the abdomen toward the umbilicus in each quadrant. Expect the umbilicus to move toward the stimulus. Plantar reflex, L4S2. Stroke the lateral sole of the foot from the heel to the ball. Normal response in adults. Plantar flexion of the toes, toes curl down. Abnormal response, Babinski sign, extension of the big toe and fanning of other toes, indicates upper motor neuron lesion. Other reflexes. Corneal reflex. Touching the cornea with a wisp of cotton should elicit blinking. Light reflex. Shining a light into the eye causes pupillary constriction, direct and consensual. 3. Cranial nerves, CNs. There are 12 pairs of cranial nerves, each with specific functions. A thorough cranial nerve exam is essential in any neurological assessment. Olfactory, CNI. Function. Smell, assessment. Test each nostril with familiar scents, e.g., coffee, vanilla. Note any anosmia, loss of smell. Optic, CN2. Function. Vision, assessment. Visual acuity, Snellen chart. Visual fields, fundoscopic exam, check the optic disc. Oculomotor, CN3. Function. Eye movement, medial, superior, and inferior rectus muscles, inferior oblique muscle, pupillary constriction, eyelid elevation. Assessment. Pupillary light reflex, cardinal fields of gaze, eye movement, ptosis, drooping eyelid. Trochlear, CNIV. Function. Eye movement, superior oblique muscle. Assessment. Cardinal fields of gaze, particularly downward and inward movement. Trigeminal, CNV. Function. Sensory to the face, mastication, chewing, muscles. Assessment. Light touch and pain sensation on face, 3 divisions, ophthalmic, maxillary, mandibular. Palpate muscles of mastication while the patient clenches their jaw. Abducens, CNV. Function. Eye movement, lateral rectus muscle. Assessment. Cardinal fields of gaze, lateral movement of the eye. Facial, CN7. Function. Facial expression, taste, anterior 2/3 of tongue, lacrimation, salivation. Assessment. Observe facial symmetry, ask patient to raise eyebrows, smile, puff out cheeks. Test taste on the anterior tongue with salty and sweet solutions. Vestibulocochlear, CN8. Function. Hearing and balance. Assessment. Hearing, whisper test, Weber and Rinne tests. Balance. Observe patient walking, Romberg test. Glossopharyngeal, CNX. Function. Taste, posterior 1/3 of tongue, swallowing, gag reflex, salivation. Assessment. Taste on posterior tongue, gag reflex. Vagus, CNX. Function. Innervates many organs, motor and sensory for pharynx and larynx, parasympathetic control. Assessment. Observe voice, gag reflex, soft palate movement. Accessory, CN11. Function. Shoulder and neck movement. Assessment. Shoulder shrug and head rotation against resistance. Hypoglossal, CN12. Function. Tongue movement. Assessment. Inspect tongue for atrophy. Ask patient to stick out tongue. Note any deviation or weakness. Professor Hammer's advice for mastery: practice, practice, practice. Perform these assessments frequently on your peers and in simulated environments. Be systematic. Develop a consistent approach to each exam. Relate findings. Correlate your findings on the exam with potential anatomical deficits. This will help you with diagnosis. Understand limitations. Be aware of the limitations of each assessment, e.g., a patient on medications might have an altered GCS. Document carefully. Your documentation is as important as the assessment itself. Ask questions. Don't hesitate to ask your instructors or clinicians for clarification. Final thoughts. These are powerful tools for assessing neurological status. Mastering these assessments will not only help you pass exams but also equip you with the skills to provide quality care for your future patients. Remember to always approach your assessments with a combination of rigor, attention to detail, and compassionate care. Professor Hammer's memory-boosting techniques for neurological assessments lets make this material not just memorizable but understandable and therefore memorable. I Glasgow Coma Scale, GCS. The I Verbal Motor Framework. The core concept. think of the GCS as a method to gauge how well the brain is responding to stimuli. The less the brain responds, the lower the score. Memory trick. EVM is easy to remember, and is the order for the assessment. Eyes, E. Start with the most external response, eyes. Think of it as the first, most superficial layer of response. 4 3 2 1. Use a downward count in your head as you progress through the stimuli. The numbers are highest for the more intact response, and lowest as function decreases. Spontaneous, speech, pain, none. This should now be very easy. Verbal, V. This is the middle layer, more complex than eye movement, but less complex than a physical action. 5 4 3 2 1. Use a downward count again. You can also try to remember using OCISN, oriented, confused, inappropriate, sounds, none. Imagine each number has a characteristic of speech. The patient goes from oriented, to confused, to using inappropriate words, to making sounds that make no sense, to finally having no verbal response. Motor, M, the deepest and most complex response, involving physical action. 6 5 4 3 2 1. This follows the general trend in the scale. You should have a general idea for the numbers at this point. Obeys, localizes, withdraws, decorticate, decerebrate, none, create a mental image of each level. Obeying commands is a high-level function. Locating the source of the pain is a purposeful action, and a withdrawal is less specific. Then imagine decorticate, decerebrate postures as the most deteriorated function, and then no response at the very end. Mnemonic for abnormal motor responses. Decorticate, to the core, flexed. Think of the arms flexing inward, towards the core of the body. Decerebrate, extended, outwards. Think of the arms extending outwards. 2. Reflexes, the sensory in, motor out, framework, the core concept. Reflexes are a quick, involuntary arc that bypasses conscious thought. Think of a circuit with an input and output. Memory trick. DTRs are deep, superficial is skin, deep tendons, skin surface. Deep tendon reflexes, DTRs. Think. These involve muscles and tendons. They are deep in the tissue. Action. Strike a tendon, observe the muscle response. Imagine striking each tendon with the hammer. Locations. Key areas like your biceps, triceps, knee and ankle. Picture your body as you would tap at each location. Grading. Remember that +2 is normal, 0 is absent, 1+ is low, and 3-4+ is an overreaction. Superficial reflexes. Think. These involve the skin. They are superficial. Action. Stroke the skin, observe a muscular movement. Think about the skin movements as you perform the test. Abdominal reflex. Imagine drawing your fingers in on the stomach toward the belly button, like a belly button vortex. Plantar reflex. Visualize the stroke on the foot. If the patient has a Babinski, use the word up to remember it. The toes turn up, memory trick for DTRs, myotome. Association. Think of the nerves that provide the reflex as myotomes. These muscles are controlled by a specific spinal cord level and associated nerve. C5/6. Biceps, brachioradialis. C7. Triceps, L2-L4. Patellar, S1-S2. Achilles clinical significance, general, hypo. Lower, hyper. Upper, remember that hyporeflexia often points to lower motor neuron problems, like peripheral nerve issues, and hyperreflexia points to upper motor neuron issues, like brain, spinal cord injuries. 3. Cranial nerves, the, on old Olympus towering top, a Finn and German viewed some hops, mnemonic the core concept. These nerves emerge directly from the brain and control head, neck functions. They are a set of 12 wires, each with its specific job. Mnemonic for remembering the names in order. On old Olympus towering top, a Finn and German viewed some hops. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, auditory, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. Memory tricks for function, use keywords. CNI, olfactory, smell. CN2, optic, CN3, oculomotor, eye mover, most eye muscles, pupils. CNIV, trochlear, eye down and in. Think of IV, having a downward line, CNV, trigeminal, face sensation, mastication. Think of a 5-pointed star on the face, this is also a trio. CNV, abducens, eye, lateral, think of V as having a lateral, sideways movement. CN7, facial, face movement, taste, anterior tongue. Think of 7 senses. CN8, vestibulocochlear, hear, balance. Think of the infinity sign, balance and hearing. CNX, glossopharyngeal, taste, posterior tongue, gag. Think 9 as also the gagging number. CNX, vagus, the vagabond nerve. Heart, lungs, gut. Think of the vagus nerve reaching out to many organs. CN11, accessory, shoulder shrug. Think of lifting your head and shoulders. CN12, hypoglossal, tongue movement. Think of the tongue at the bottom of the mouth. The number 12 looks like a tongue. Memory tricks for assessment, visual. Imagine going through the physical exams with each nerve, visualizing how you test each function, e.g., smelling coffee, checking vision with a chart, moving the eyes, testing taste, etc. This visualization helps create a mental pathway to remember the assessment steps. Professor Hammer's memory maximization techniques, the location method, memory palace, create a familiar place in your mind, your house, your drive to school. As you learn each topic, place it in a location. For example, the GCS in your kitchen, reflexes in your living room, and cranial nerves in your bedroom. This spatial component adds to recall. The story method, create a bizarre story that connects concepts or nerves. The more ridiculous, the better you'll remember it. Think, a smelly optic nerve went to the park with a wobbly ear. Active recall. Don't just review, test yourself. After studying a section, cover your notes and try to recall the information from scratch. This builds neural connections much more effectively than passive rereading. Spaced repetition. Review concepts at increasing intervals. Don't cram. Review after 1 hour, then 1 day, then 3 days, then 1 week, etc. This strengthens long-term memory. Teach it. As I said before, explaining the information to another student, or even your pet, solidifies the information in your own brain. Final thoughts. By using these mnemonic and memory techniques, you'll be able to recall these concepts quickly and accurately. This is not just about passing an exam, it's about building a solid foundation for clinical practice. You need to be able to quickly and confidently perform these assessments, and that requires both knowledge and memory.